And now on to our next session, which is the research year in review with a round robin format. We're all eager to hear about what's going on out there in terms of research. I'm going to hand this off now to Team Phenomenal Hope President and Founder, one of my personal heroes, Dr. Patricia George. She's going to moderate this session, and I can tell you I know her very well, and she spends every waking minute of her life fighting for our patients. Take it away, Patty.
Thank you so much, Carl. And again, congrats to both Paula and Dr. Roop. Super excited about what you've done and what you're about to do. It's amazing. This has been a great session so far, and I appreciate what everybody's talked about. This next session is going to bring you the latest in terms of research and exciting things that are both published in this last year in the time of the pandemic, as well as sort of really exciting things potentially coming down the pipeline. One of the most exciting parts about being a pulmonary hypertension physician is that there's a lot of progress that has been made in our field and continues to be made in our field. And so we're going to share that with you today. So this session is going to be a quick like round robin type format. We have 4 experts who will be speaking from studies that they are either primary investigators in and or are involved in early studies that are both published and underway. And so with that, I'll introduce our first speaker, Dr. Dave Badesch. Dr. Badesch is part of an outstanding team of caregivers who have earned a worldwide reputation for excellence in the field of pulmonary hypertension at the University of Colorado Health. He's dedicated his career to improving the treatment of patients who are afflicted with pulmonary arterial hypertension, and he prefers to apply an evidence-based approach towards therapies. Dr. Badesch is a member and or chairman of many PAH-related planning committees and presents lectures on current clinical trials and advances in the field of PAH. And he's also an avid and quite skilled bike rider in his spare time. And so with that, I'm going to turn this over to Dr. Badesch to talk to us about one of the latest exciting molecules in pulmonary arterial hypertension.
Well, hi, Patty. And hi, Carl, Hap. It's wonderful to see you guys. Thank you for this opportunity to speak briefly about sotatercept. I'm going to begin by saying that this is not an FDA-approved therapy. It's still under investigation. And it's based on work that was done over 20 years ago now. Many of you may know that the gene, the BMPR2 receptor gene was found to be involved in many cases of heritable or familial genetic pulmonary hypertension about 20 years ago by 2 centers, the center at Vanderbilt and the center at Columbia, virtually simultaneously. And it's interesting, in the 20 subsequent years or so, we really have not developed any therapies based directly upon that knowledge. This is similar, I think, in some ways to what's happened in the cystic fibrosis field, where the discovery of CFTR was maybe led the development of therapies based on that knowledge by 15 or 20 years. And so that sort of lag time is unfortunately fairly typical in medicine. But anyway, this therapy is called sotatercept, and it's a drug that focuses on rebalancing activin and GDF signaling with BMP signaling. And to just to tell you briefly about the mechanism or putative mechanism of action of this drug, it binds ligands to a receptor that causes cellular proliferation or remodeling of blood vessels. And so it sort of blocks their activity and thereby allows relatively increased activity through the BMP pathway, which has anti-proliferative activity. So it rebalances signaling in a favorable way that hopefully leads to favorable structural changes in pulmonary arteries. Many of our therapies to date, and you know, there have been 3 therapeutic pathways approached to date: the prostacyclin pathway, the endothelin receptor antagonist pathway, and the PDE5 pathway, or the nitric oxide pathway. Those drugs are largely focused on vasorelaxation or preventing vasoconstriction. They do tend to have perhaps some anti-proliferative activity, but they're not really focused on that component of the disease. And we do know that the disease, pulmonary arterial hypertension, is largely characterized by structural remodeling of vessels with cellular proliferation of endothelial and smooth muscle cells in the vessel wall, leading to a narrowed vessel wall. So this drug, it was designed, it got kind of a binding moiety that's bound to part of an antibody. And that drug is designed to bind these activins and GDFs that activate this kind of bad pathway or pro-proliferative pathway. It's been studied thus far in a phase 2 clinical trial in pulmonary arterial hypertension that was completed just prior to the COVID pandemic. It was really fortuitous that we were able to get it done just prior to the pandemic occurring. And the phase 2 study, the primary endpoint was a decrease in pulmonary vascular resistance. And secondary endpoints included things like 6-minute walk distance, BNP levels, brain natriuretic peptide levels, and other secondary endpoints. The study did meet the primary endpoint of decreasing pulmonary vascular resistance relative to what was seen with placebo. It also improved 6-minute walk distance and decreased BNP levels. So across a number of endpoints, concordant results were seen, meaning seeing favorable changes in a similar direction. And that's what we like to see in clinical trials. So the drug is now undergoing phase 3 studies. Those phase 3 clinical trials have just begun. They're worldwide studies like the phase 2 study was. The phase 2 study was published in the New England Journal of Medicine in early April of this year. We're hopeful that maybe we'll see results in the phase 3 trials that support what we saw in phase 2. And that might eventually lead to a new therapeutic option for patients with pulmonary hypertension. And I'll stop there. Thanks very much for the opportunity to join you, Patty. Appreciate it.
Thank you so much, Dr. Badesch. That's great, a great summary of a very exciting new molecule. So eager to see what happens in the phase 3. All right, moving right along. Now we have Dr. Vinicio de Jesus Perez, who is an associate professor of medicine and staff physician of the Stanford Adult Pulmonary Hypertension Clinic. Beside his clinical work, Dr. de Jesus Perez is the principal investigator of a research program that investigates the genetic and molecular mechanisms of PH with the ultimate goal of identifying new therapeutic targets. As a medical professional belonging to a minority group, Dr. de Jesus Perez is involved in academic endeavors seeking to improve access to care for patients with disadvantageous ethnic backgrounds and also promote diversity in medicine. So with that, I'll give it to you, Vinicio.
Thank you so much. It is a real pleasure to be with all of you today. So I'm going to tell you about a project that we've done in conjunction with the PH Aware Patient Advocacy Society. It's an app-based remote monitoring of the 6-minute walk test. We call this the Dynamite Study. And I'm presenting also on behalf of my colleague and friend, Dr. Roham Zamanian, who's the co-PI in this project. We all know that the 6-minute walk is a critical component of evaluation, assessment, and management decisions related to pulmonary hypertension. It's part of every single clinical trial out there, and it's part of our risk stratification scores, which guide much of our clinical decision making. However, this is a test that has to be carried out in the clinic environment. It has to be supervised. It is extremely cumbersome, and particularly in this day and age where we are surviving a pandemic that has limited the capacity of patients to come to our clinics, let alone other patients that even in the absence of a pandemic have problems arriving. So the question is there a way that we can actually do this in a way that the patient can actually do the study close to their home or in without supervision, and then send us that information. And this is what we did in collaboration. So PH-Aware developed an app that does that. It's compatible with the iWatch. Essentially what it works is, this is your iWatch. This is once you click the app, this is what you see. It will ask you whether you will perform the test indoor, outdoor. You will be asked how your breathing is, exactly like your pulmonary function specialist will be doing during the test. You will carry out the 6-minute walk that this will measure the amount of time. They will allow you to rest. And then it will once again ask you, how's your breathing? Ultimately, it will summarize all the parameters from that particular study and then upload it to us. We're going to get a lot of information from this that is going to be important in terms of analyzing the data. What you see here is the design of the study so far. 60 days prior to starting the study, we're actually screening our patients. We're calling them, we're looking at their charts, we're selecting those patients that are willing, able, and compatible with the study. Once we do this, we will send them the watch. We will calibrate the watch in clinic. During that visit, we're conducting the assessment that we will carry out on a standard visit, but they will also undergo a supervised indoor and outdoor 6-minute walk test to calibrate with the watch. After that, for the next 3 months, the patient is doing daily walks to the most of their capacity. And then this information, once the 3 months are up, we will do a closeout where we will capture once again an indoor, outdoor, and this information then will be saved. So far we have done this with 57 patients. We have over 2,000 walks that we're currently in the process of analyzing. But what you can see is most of our patients are functional class 2, age of 47. It covers the whole a wide spectrum of etiologies, and the hemodynamic parameters we're seeing are patients who are very representative of what our patient population is. So how are we doing here? Well, indoor and outdoor, we are actually comparing against the gold standard, which is the supervised 6-minute walk distance, indoor and outdoor. And what we're seeing is that walking distance and summary distance actually correlate very well, reasonably well. The pedometer distance, which is inherent to the actual device capturing this information, is less clear, and we have some ideas that, I mean, a part of this is actually the actual device itself, the GPS. The other thing also is that with outdoor, it seems that it's a little bit less, the correlation is a little less. And again, this is something that we're currently exploring. But what you'll see here is that true summary distance, this is somebody who did this throughout the 140 days. And we can actually correlate some of this with the symptomatology of the patients. You can see that days when the patient is walking less, they're actually feeling less better. And then as they're getting back wagon, you can see that the 6-minute walk also correlates with that. So I think it's a good way to actually correlate what the device is telling us with what the patient is telling us. So at this juncture, we're working on improving the accuracy, the correlation, and we're also capturing other parameters such as heart rate data, which are going to be critical for us as we take this to the next level, which is having our patients be able to use this in conjunction with us to make the best decisions and have the best quality of life possible for our patients. So with that, thank you very much. This is our team. And this is our colleagues in PH-Aware, John Hess and Steve Van Berg. Back to you, Patty.
Thank you so much, Benicio. That is fascinating, super exciting. I've been following your work, and it'll be great to see the next results that you guys find in the validation of this app. So now we're going to move on to Dr. Stephen Nathan. And Dr. Nathan is someone who straddles the divide between pulmonary hypertension and pulmonary fibrosis. Dr. Nathan is the Director of Advanced Lung Disease and Lung Transplant at Inova Fairfax Hospital. He's also a professor of medical education at the University of Virginia, and his main interests of research include interstitial lung disease, pulmonary hypertension, and lung transplantation. And he has been a leader in the field of group 3 pulmonary hypertension, specifically pulmonary hypertension due to lung disease. And so with that, I'll turn it over to Dr. Nathan.
Thank you, Patty, and thanks for the opportunity to talk to the group. And just have a couple of slides to share with everyone, titled, as you can see, Time for Increased Attention to Pulmonary Hypertension Associated with Interstitial Lung Disease. Next slide, please. What's not showing on the left is the severity of pulmonary hypertension that we typically see in patients with lung disease. When patients with lung disease get pulmonary hypertension, it's generally mild to perhaps moderate, with most of them sitting with mean pulmonary artery pressures between around 25 and 30. And yet, even though they have mild pulmonary hypertension, the impact on outcomes is quite profound. You can see to the right, this is a survival curve of patients with IPF, and those with pulmonary hypertension, the 1-year mortality is around 40%. And, you know, we have all these different medications that are approved for group 1 pulmonary arterial hypertension. And I remember something that Hap, hopefully Hap's still on the call, had mentioned, and it's always resonated with me. We have all these toys to play with for group 1 pulmonary arterial hypertension. And what about patients beyond group 1? As most folks probably know, there's just one medication approved beyond group 1, and that's riociguat for group 4 CTEPH, chronic thromboembolic pulmonary hypertension. But what about lung disease and pulmonary hypertension related to lung disease? Because this is you know, probably the biggest group of patients with pulmonary hypertension. Maybe heart failure is another big group, but certainly between COPD, emphysema, all the different interstitial lung diseases, there are many, many patients who develop these conditions, which then gets complicated by pulmonary hypertension, which when it does occur is associated with worse outcomes and worse functional impairment. Next slide, please. So this is a concept slide, and it's a build. Essentially, you can regard these patients as having 2 diseases, lung disease and pulmonary hypertension, and what's causing the limiting factor. And you can work your way through this build, and I'll talk to it. Next. Is it from the lung disease? Is it from the pulmonary hypertension? Next. And if it is from, next. If it is from, oh, that didn't work out too well. Don't worry about it. The point is, if their limitation is from the pulmonary hypertension, can we treat it with one of our medications that we have for group 1 and improve patients' breathing? And at the same time, can we potentially improve the overall outcomes, including survival? Next slide, please. So there've been many stabs at this, so to speak, a lot of different studies, retrospective reviews, small open label series. There was one big study of riociguat in patients with a broad basket of interstitial lung diseases called the idiopathic interstitial pneumonias. That encompasses IPF as well as a number of other conditions. And that study, which was called RISE-RP, unfortunately had to get halted early because it appeared like there was increased harm in the treatment arm. And then what happened was we didn't give up as a community. The next thing we looked to study was inhaled treprostinil, also known as Tarvesa, inhaled treprostinil, which is approved for group 1 pulmonary arterial hypertension. We looked at if this might have a role in pulmonary hypertension due to interstitial lung disease. I was privileged to present this at ATS last year. It was published in the New England Journal of Medicine in January of this year. And this is a brief outline of the study. This has been the largest study to date in group 3 pulmonary hypertension, with the primary endpoint being the 6-minute walk distance. Next slide, please. This shows the demographics of the group, and we'll breeze through that. This is the outcome, the 6-minute walk at 16 weeks, which was statistically significant depending on which methodology was used. It was either 21 meters or 31 meters, which is right in the ballpark of the original study that got inhaled treprostinil approved. That was the TRIUMPH study from 11 years ago, where the distance difference was around 21 meters. Next slide, please. Next. And also a very important secondary endpoint was time to clinical worsening. And this was also favorable towards inhaled treprostinil. And you can see the significance there with a p-value of 0.04. We had a biomarker, the NT-proBNP. I apologize, there's a thunderstorm in the background here. And this also showed evidence of benefit, implying reduced right ventricular stretch and improved right ventricular compensation. For the inhaled treprostinil arm, the NT-proBNP went down, whereas for the placebo arm, it actually went up. Next slide, please. What was also pretty cool about the study is that we looked at lung function as a safety endpoint. We wanted to make sure we're giving patients with interstitial lung disease an inhaled medication. We had to make sure there was no harm, no foul. And in actual fact, what we saw was that lung function appeared to be significantly better in the patients who got inhaled treprostinil, seen mostly in the patients with IPF. And this is kind of open another door for research to look at inhaled treprostinil for its anti-fibrosis properties. And there's a study that's ongoing now looking at inhaled treprostinil for this particular indication in patients with idiopathic pulmonary fibrosis. So I think the PAH community can be especially proud because as a community, we came up with this medication that is approved for group 1 PAH, but now we have a medication that's going to help patients with group 3 pulmonary hypertension. So group 1 has led the way, and group 3 pulmonary hypertension is happy to follow in the trail that's been blazed by group 1 pulmonary arterial hypertension. So on March the 31st of this year, the FDA granted an approval to inhale treprostinil for PH associated with interstitial lung disease, which marks the first therapy approved for group 3 pulmonary hypertension and only the second therapy approved beyond group 1 pulmonary arterial hypertension. So I really think that this represents a paradigm shift in how we manage our patients with interstitial lung disease. I think we've got to lower the bar to look for pulmonary hypertension, perhaps get more right heart caths in these patients looking for pulmonary hypertension, because now we have a medication that can truly help them. So I believe that's my last slide, and I'll stop right there. Thanks.
Oh, fantastic. Thank you for that presentation. It's super exciting to finally have an approved therapy for these patients who have PH-ILD. So with that, last but not least in this session, we have Dr. Leslie Spikes. She is a pulmonary and critical care physician and an associate professor of medicine at the University of Kansas Medical Center in Kansas City. And her specific passion in this field is pulmonary hypertension. And she's been involved in these some of these trials looking at newer molecules that are kind of a little further down the pipeline and yet very exciting. She is also the co-director of the Pulmonary Hypertension Comprehensive Care Center at the University of Kansas Medical Center. So with that, I'm going to turn it over to Dr. Spikes and look forward to hearing what she has to say.
Good afternoon, everyone. I am, like Dr. George says, I'm Leslie Spikes from the University of Kansas. And my part is just going to go over these fairly new molecules and trials that are just getting started, but are very exciting. As some of the previous speakers have mentioned, our approved medications are mostly for pulmonary arterial hypertension and group 1 disease. And we've really focused on these 3 pathways significantly over the past 20 some years: the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. And the trials and the molecules I'm going to talk about here in just the next few minutes are something that are going to target other ways to treat pulmonary arterial hypertension and be an additional therapy to these already great medications that we already have. So the trials I'm going to talk about are all phase 2 clinical trials. And really what that means is that they have passed. They've gotten a good score on their phase 1 studies. So they've been verified that they're safe in humans and can go on to further be to further be studied in patients. They are randomized, which means that some patients will get treatment and some will still get placebo. And really what their main target is, are we going to get more information on how well these new PH treatments work in the disease process? And also they continue to gather more data on the safety and the side effects of these new medicines. So the first one we're going to talk about, and these are so new that they don't even have other names besides their kind of hard ones, the rhododristat ethyl. This works on the serotonin pathway, which again is different from the 3 pathways that we have with our other known medications. I will also add in here too that these molecules I'm going to talk about, these studies are just at this time for group 1 pulmonary arterial hypertension patients. We just heard some exciting news about group 3, but these are new enough that we're still just studying them in group 1 PAH. So why is blocking peripheral serotonin helpful in pulmonary arterial hypertension? We've known for a while now, for many years, that excess serotonin has been shown to contribute to the narrowing of the pulmonary arteries, which is what helps lead to pulmonary arterial hypertension. And so this will peripherally block that serotonin. And the neat thing also about this particular molecule is that it is not uptaken by the central nervous system. It will be mainly focused more systemically besides the blood-brain barrier. It will be taken by mouth twice daily. And again, this is an additional treatment that can be added on with other existing pulmonary arterial hypertension treatments. The next one I'm going to talk about is called seralutinib. It was specifically formulated for the treatment of pulmonary arterial hypertension, and it helps inhibit molecules, including the BMPR2 gene that I think Dr. Badesch mentioned earlier in his talk. But it helps inhibit these molecules that contribute to the narrowing, again, of the pulmonary arteries and the development of PAH. It is actually an inhaled medication. It is different in a good way from the Tyvaso machine that we all know about. This is going to be a dry powder inhaler taken twice daily. And this inhaler is much smaller, kind of similar to something you may have seen asthma or COPD patients have. And then again, it's being studied for addition onto other pulmonary arterial hypertension treatments. And then last but not least, pimzivaptidil is a VIP analog. And VIP stands for vasoactive intestinal peptide. And what does that mean? And why will that help pulmonary arterial hypertension patients? VIP has been known for quite some time in medicine as a naturally occurring hormone that is known to lower blood pressure, including in the lungs, which is what we want to do in PAH. And it also has been shown to reduce inflammation and scarring as well. This is a little bit more time intensive in terms of it's not oral or inhaled. It's a once weekly subcutaneous injection, and it is being studied for other PAH treatments. So in conclusion, these are all in phase 2 trials, just getting up and running in group 1 pulmonary arterial hypertension patients. But I think preliminary data shows that, again, very exciting with new different targets to treat, and kind of helps load our armamentarium for the treatment of pulmonary arterial hypertension. So it's very exciting, and we will definitely have more news on this to come.
Fantastic. Thank you so much, Leslie. Great talk. I think that being able to pronounce the new molecules' names is a talent in and of itself.
I had to practice a little.
Yeah. It's just really exciting for us to kind of get an early view of things perhaps coming down the pipeline. So we'll see where these things go. I have one quick question for Dr. Spikes, and then I'll move on to some in the chat. So Dr. Spikes, you're talking about these molecules, they're phase 2. Can you give the audience like a general gestalt for how long it would take to get a molecule from concept phase 1-2 to phase 3 and drug approval? Like, is this something that's a couple of years, or how long would you say it usually takes for molecules that succeed?
I wish I could say it takes months, but no, it really, even in promising trials, to go from each phase usually takes months to years. So while it's exciting and new, I think we have some time, definitely time before they can come to market and be accessible for everyone.
Great, thank you. Okay, I'm just going to go through a few questions here. So Dr. Nathan, you mentioned the inhaled treprostinil for PH-ILD. Do you see this becoming standard of care for group 3 PH-ILD? And if yes, how soon?
I think it should be standard of care, and as soon as now, it is approved by the FDA, so it's passed through a pretty stringent process. I think that it gives us something else to offer these patients who have sometimes, can have a very a bad course in terms of what their prognosis is. We do have the antifibrotics that are available for patients with interstitial lung disease, nintedanib and pirfenidone, but this is something else. And I think it's potentially the start of combination therapy for the various forms of interstitial lung disease. Some patients might end up on one of the antifibrotics, and then if or when they do progress and they develop pulmonary hypertension, this is something else that we can have available to kind of catch them and slow down or halt the rate of disease progression. So I do believe it should be standard of care. It might take a little while for this to gain traction amongst practitioners in the community. It's only available and approved in the US at this time. I'm not sure what the status is in other countries, but I think that this certainly is a reason for optimism for patients who have interstitial lung disease moving forward.
Great. One question, a follow-up question to that is, will a right heart catheterization be required to assess the pH component of PH-ILD as was done within the study? Because this may not be recommended in the FDA labeling.
I think you always need a right heart cath for any form of pulmonary hypertension to diagnose pulmonary hypertension. And so absolutely 100%. I don't think that this is something that should be started empirically based on suspicion. Much like group 1, group 4, you always need a right heart cath for definitive diagnosis. We see echo both overestimate as well as underestimate what the pressures are. We need to know what the left-sided filling pressures are to know that there isn't a component of group 2 pulmonary hypertension. So absolutely, you always need a right heart cath.
Great. And coming back to Benicio, with the real quick question on the 6-minute walk test app, is it available for Android or is it only in iOS?
No, it's on iOS. This was a decision made at the level of PH Aware based on the capabilities of the iWatch. Once we validate this app, our next step will be to broaden the the applicability to other systems outside of iOS. So stay tuned. That's in the horizon.
It's quite exciting to see things like actigraphy and the concept of acquiring what we call in the field between visit data by, rather than having patients. So for people in the audience, rather than doing a clinical trial where you just, 4 months later, repeat a 6-minute walk test and see how far the patient walks or how less far they walk. There are these trials now where they're using things like an actigraph, like a Fitbit type technology, and trying to quantify daily activity levels or overall average daily activity levels, or what we call moderate or vigorous activity, which is like walking upstairs and doing maybe light exercise. So Benicio, how would this app complement current actigraph stuff, actigraph-based studies? Do you see it replacing or being something that you would use in addition?
I think our vision is that this app is not going to be limited just to capturing distance, steps. We believe that this is going to be a centralized hub that will be capturing a comprehensive list of parameters. That's very similar to what we will capture if the patient was in-house. For example, as I alluded to, this app is also now allowing us to capture heart rate, so we can measure maximum predicted heart rate reserve. We actually, taking advantage of the new iPhone and iWatch capabilities, we're actually also going to start capturing oxygenation. We're going to start capturing EKG data. I mean, remember, we're also doing this in parallel, and we're collaborating with colleagues from the Apple Heart Study, which is a huge study that's been capturing data that has helped in terms of identifying patients at risk of atrial fibrillation, dysrhythmia, and other anomalies. So we're building on a well-suited set of applications that will allow us to really capture a comprehensive picture of our patients. It doesn't replace the capacity, it doesn't replace us being able to call a patient, but as I alluded to, if we have some trends that look like the patient is not doing that well, or it's troublesome, we will call the patient. And again, it doesn't replace a patient, what the patient will tell us of how they're feeling. Last but not least, now that we're seeing other wearables, such as, for example, the CardioMEMS device, for example, that may soon be part also of this, if we can find a way to integrate these systems, it will provide for the first time a unique, deep phenotyping look that will give us power to us as physicians, and to the patient, it will give peace of mind that, the communication, that bond between the patient and the physician is well suited to really target the disease, the pH, before it can evolve. So it gives also peace of mind, and that's our goal, to make sure our patients have peace of mind and the best possible therapy we can offer.
Great, thank you. One last quick question. Dr. Spikes, with the first molecule that you mentioned, rodatristat ethyl, since it's involved in the serotonin pathway, are there any implications for patients who are taking SSRIs? Do you know?
There are, and in fact, there's very, in this particular study, the SSRIs are taken into account, as well as depression scores and other things that are not included in some of these other clinical trials. The reason that this is probably safe, even in patients that take these, is this is, again, a peripheral serotonin blocker. So it doesn't necessarily go, it's not supposed to go across that blood-brain barrier, which is what our SSRIs are used for. But yes, there are some potential implications there.
Fantastic, thank you. So with that, we're running out of time, so I'm going to thank our panelists. Thank you again so much for giving these great summaries about what's going on and what's coming down the pipeline. And I'll turn it back to Carl.
Thank you, Patty. And I want to thank my good friends, Dr. Dave Badesch and Dr. Vinicio de Jesus Perez, Drs. Nathan and Dr. Spikes, for their time today. It strikes me once again just how fortunate we are to have such dedicated, brilliant, committed medical professionals and researchers working so hard on behalf of our patients. So thank you for all of them, and thank you from the bottom of my heart for everything that you do.